Hi, everyone. Welcome to our exciting medical science lecture titled What is Evidence-Based Medicine and Why Does It Matter? Thank you very much for joining us. My name is Sean Lau. So I'm currently a BSc Cancer Biomedicine student here at UCL and your chair for today's event. So today's fascinating lecture will address what the exact term evidence-based medicine means, why is it useful, and what can we do to use it more effectively. So we want to keep these lectures as interactive as possible. So please, make use of Twitter and especially the Q&A function on Zoom to submit any of your questions to our speaker. Please feel free to do it throughout the lecture. And at the end, we'll answer some of your questions and hopefully have a great discussion. So the hashtag to use on Twitter is hashtag FMS lectures. So now I'm delighted to now introduce our speaker. We have Kurinchi Gurusamy. Professor Gurusamy is a professor of evidence-based medicine and surgery, the head of research at Division of Surgery and Interventional Science, and the lead surgical and interventional group at Comprehensive Clinical Trials Unit at UCL. So he's traditionally a surgeon by background, and his current focus is on clinical research and teaching with an aim to achieve high quality healthcare for all. So thank you for joining us today. And now over to you, Professor.
Thank you very much, Sean. Thank you all for attending this lecture. Today, I will talk about what evidence-based medicine means, why it is useful, major criticisms and limitations of evidence-based medicine, role of evidence-based medicine in clinical practice guidelines and shared decision-making, what we can do to use evidence-based medicine more effectively. Before we start, I hand over to Sean, who will talk through some questions with you.
So a poll will briefly pop up soon with these two questions, well, right now. And just for the fact, I'll read it out really quickly. So question 1, do you want to know the truth about whether treatment works before you receive the treatment? Do you want to be involved in medical decisions about yourself? And when you go out with your friends, do you check individually or collectively about how much money you can spend before going out? So feel free to input your questions, and we'll look through the results really briefly after you guys have put it in. So give it about a minute or so. So most of you have voted. So we have roughly 90% people say that they do want to know the truth about whether treatment works or not, with 8% maybe, which is quite interesting. And overwhelming majority, 97% says they do want to be involved in their own medical decision. However, with the third question, it's roughly split. So most people do check individually and collectively how much money to spend for going out. However, 26% and 20% say no or maybe. So moving on, back to you, Professor.
I link up these questions with what evidence-based medicine is shortly. What is evidence-based medicine? Sackett and colleagues define evidence-based medicine as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. There are 3 components for evidence-based medicine. That includes best evidence from systematic research, patient preferences, and available resources, which include clinical expertise and facilities. Now you can link these questions that I asked in the beginning with these 3 aspects. So people want to know evidence that a treatment works before they undergo the treatment. So 90% of you said yes to that. And 97% want to be involved in decisions about themselves. So that's an overwhelming number, 97%. Of course, with resources, you're not sure. There is a split in the audience. We'll look at each of these components in the next few slides. The first component is best evidence, and we said best evidence from systematic research. What do we mean by systematic research? This means systematically looking for studies that provide relevant information. This is like a detective who goes about systematically gathering all the evidence. This may include basic research or preclinical research, such as animal studies or cell culture studies, but the major component should be clinical research. There are different types of clinical research. In the context of clinical research, diagnosis or diagnostic clinical research is research aimed at distinguishing people with and without an illness. And here, diagnosis is a broad category, and it can include clinical examination, lab-based tests, self-administered tests like lateral flow tests for COVID-19, and so on. I have listed the common types of diagnostic research studies that we find in literature. In terms of prognostic clinical research, we look at factors that influence the development or worsening of the illness. That means we want to predict whether somebody will develop illness or whether their illness will worsen based on some factors. I have listed some of the factors in this slide, and common patient factors are age, gender, comorbidities, or coexisting illnesses. There are disease-related factors, for example, the type of disease or severity of disease. There are other factors. Many times, it's not a single factor that determines the prognosis. It's usually a combination of factors. And when there is a combination of factors, we use something called prognostic scoring systems, which give different weight for these factors and predict whether someone will develop the disease or whether their illness will worsen. That is prognostic clinical research. Before we go on to the next type of clinical research, we need to clarify some terms. This relates to intervention versus treatment. These two terms are used interchangeably very often. But there are subtle differences between these terms. Treatment generally refers to curative, palliative, or symptomatic measures after the disease has occurred. So here, your disease has occurred and people are treating them actively. But intervention also refers to preventive measures in addition to curative, palliative, or symptomatic treatments. For example, exercise to prevent an illness. In the context of clinical research, intervention research usually is aimed at finding how well an intervention works. And there are broad categories of interventions, some of which are listed in the slide. And this includes medicines, surgery, nutritional interventions, physiotherapy, advice, vaccination. Many times, it's also a combination of interventions that's used. So they are not used alone, but a combination of interventions are used. For example, the physiotherapy can be combined with advice, or surgery is combined with physiotherapy, and so on. The next component of evidence-based medicine is patient preferences. Different patients have different preferences. This is often misunderstood by doctors. Patients should receive information on best research evidence and expertise available. That means they should receive information about all the alternate treatments available, including their advantages and disadvantages. Patient preference varies. For example, some people are willing to accept a shorter duration of life in return for better quality of life. Others want longer life and they are willing to accept some deficiencies or some disabilities. Now, if you want to look at people, what people who prefer the quality of life over the quantity of life, they usually choose an invasive treatment, even though the invasive treatment may be associated with the risks. On the other hand, the people who prefer the duration of life over quality of life are more likely to choose a less invasive intervention, which carries lesser risks, even if the chance of cure is less. and you can find people who are willing to take different types of risk. So patient preference varies. The third component of evidence-based medicine is resources. What do we mean by resources? We mean a wide category of items. Here we talk about clinical expertise, adequate facilities, adequate personnel, and adequate money. In terms of clinical expertise, there should be adequate clinical expertise to deliver an effective intervention. For example, gallbladder removal or cholecystectomy is usually performed through keyhole, and this is called laparoscopic cholecystectomy. It has been shown that in people with inflammation of the gallbladder, yearly laparoscopic cholecystectomy is beneficial. But you need higher surgical expertise to perform yearly laparoscopic cholecystectomy. So that means that even if there is evidence that early laparoscopic cholecystectomy is beneficial, if the hospitals do not have the sufficient surgical expertise to perform the surgery during the early phase of acute cholecystitis, it is likely to cause more harm than good to patients by performing a yearly laparoscopic cholecystectomy. So there has to be sufficient clinical expertise to deliver the complex intervention. There has to be adequate facilities and personnel. For example, even if you have a surgeon who is capable of performing early laparoscopic cholecystectomy, you need theater space. If the operation theaters are constantly full, then you cannot perform early laparoscopic cholecystectomy. Even if you have expertise, facilities, and adequate personnel, this treatment should be funded by either the government or the insurance company or by the individual, depending upon which healthcare systems you're looking at. In UK, this is the adequate money part of it is done by something called cost effectiveness. One more question before we progress to the next slides. Sean?
So again, a poll will pop up really briefly. And the question is, in your opinion, which of the three components is or are the most important? So you have to get a combination, you can get all three, or you can pick one of them. All right, there we go. So most people agree that all three, a large majority, 65%. However, 15%, the next most common, was said that evidence and patient preferences were the most important. So Professor?
Thank you very much, Sean. Looks like most people want all three components of evidence-based medicine to be implemented. So that brings us to the advantages of evidence-based medicine. Evidence-based medicine has a lot of advantages. The first thing is you can make informed decisions because you're doing a systematic review of existing research evidence. You're taking resources into account along with patient preferences. It also ensures that the resources are used optimally based on evidence. It improves quality of healthcare. Now, people who are familiar with different study designs, randomized controlled trials provide the best evidence for causative inference. And there are no randomized controlled trials demonstrating that using evidence-based medicine is better than not using evidence-based medicine. But we have some evidence in that if the evidence-based health policy was followed, mortality after heart attacks would have decreased. Now we go on to the criticisms of evidence-based medicine, and there are a lot of criticisms. The first criticism is everybody is already doing it. That is wrong. There is significant variation in clinical practice. The amount of time required to keep up with the current practice is more than the time available to do this. So we need somebody else to compile the evidence and provide that to you in a digested way. It can be conducted only from ivory towers and armchairs. That is wrong. It can be implemented practically. You just need the will to do this. The next criticism is evidence-based medicine is cookbook medicine. What does that mean? That means doing a list of things without understanding the rationale behind doing it. So people say evidence-based medicine is cookbook medicine and does not take clinical judgment into account. That is wrong. It takes available best evidence, resources, and patient preferences into account. And there is usually a good rationale for arriving at conclusions. Some people criticize evidence-based medicine as a cost-cutting exercise. Wrong. The main purpose is to identify and apply the most effective interventions to maximize duration and quality of life. Some evidence-based practices may actually increase costs. Another criticism is that evidence-based medicine is restricted to randomized controlled trials and systematic reviews. That is again wrong. We are looking for the best evidence from all the study designs. One more criticism is it prevents novel treatments from being used. That is wrong. It only stipulates that a fully informed decision is made. That means you provide information on how well existing treatments work, evidence supporting the use of novel treatments, and after providing this information to the participant, if they want to undergo the new treatment, by all means, you can use the novel treatment. One more criticism is it's only about research evidence to guide treatment. Now that is clearly wrong because we have just seen that it involves consideration of patient preferences and available resources. While some of the criticisms of evidence-based medicine are not correct, there are some other criticisms of evidence-based medicine that are real. And we call them the limitations of evidence-based medicine. Design and conduct of biased studies leads to biased research evidence. And if you use biased research evidence, you're going to make the wrong decision. So the research underpinning the decisions should be good. The methods used for analysis or interpretation may not be correct. And for example, the methods used for evidence-based medicine are developing at a rapid pace, and guidance based on older methods may be wrong. So they may have to be revised with when the newer methods are implemented. Another major limitation of evidence-based medicine is reporting bias. What is this? This means that people are publishing only positive results. And if you gather all the positive results, you would wrongly conclude that a treatment works. So this is a major problem with evidence-based medicine as it stands now. Another major limitation is that the evidence provided is assuming that the treatment works equally in all types of people who participated in research. Now, there is some evidence that this is not the case. There is currently no universally accepted solution, but people are working on a solution to address this. So there are lots of limitations for evidence-based medicine. Shall we throw it away? Okay, let's look at what alternatives are available to evidence-based medicine. We can use a treatment and hope that it works. Okay, that sounds very bad. You can use individual judgment of healthcare professional based on experience. This is a common term that a common phrase that is used when there is uncertainty, use clinical judgment. Now we have a problem with that. people recall successes more than failures. So they might conclude that a treatment is more effective and safer than it actually is. This is called a denominator problem. Of course, if people are recording their results systematically and using that to guide treatment, that is evidence-based medicine, essentially. We are talking about people not recording this information in a systematic way, but just using recall, memory recall to guide treatments. And this can lead to uninformed decisions and wrong decisions. One last question. Over to you, Sean.
So based off the lecture, do you think that the evidence-based medicine should be practiced by health professionals? Yes, no, or you're not really sure? There's no really right answer, but please feel free to fill in the poll. We'll give it about a minute again. And just very briefly as well, if any questions, please feel free to put in the Q&A function for us to answer it later and have a discussion about it. Can be anonymous if you wish, but please feel free to ask more questions. We'll leave some time for that later.
So people think.
Yeah, they do.
Yeah. Thank you, Sean. Sorry.
No worries. No worries. There's a,
yeah. Thank you. So most people think that evidence-based medicine should be practiced by healthcare professionals. That's heartening to hear. Now we look at the role of evidence-based medicine in clinical practice guidelines and shared decision-making. Before we talk about clinical practice guidelines, we need to know what clinical practice guidelines mean. Institute of Medicine defines the clinical practice guidelines as shown in the slide. I'm not going to read out the whole definition, but I have highlighted a section where it says clinical practice guidelines are something that are informed by a systematic review of evidence. That is theory. In reality, a considerable proportion of clinical practice guidelines are not supported by evidence. That's a very provocative statement, but I have the evidence to show that that is the case. Evidence-based medicine is also used in shared decision-making. What is shared decision-making? It is a collaborative process that involves a person and their healthcare provider working together to reach a joint decision about the person's care. Why is shared decision-making important? Because patients and healthcare professionals overestimate the benefits and underestimate the harms of treatment. Shared decision-making ensures that individuals are supported to make decisions that are right for them. The key components of shared decision-making are learn about the patient, tailor information, describe treatment options, and that includes evidence of benefits and risks, deliberate, and determine next step. You can see evidence-based medicine underpins shared decision-making. Clearly, there is patient preferences involved. We are talking about research evidence being used, and quite possibly during the deliberation, you would also consider the resources available. Shared decision-making is excellent, is something that is aspirational and should be done as far as possible. But there are challenges in shared decision-making. Poor patient understanding of the decision and underlying trade-offs can lead to poor patient participation. So the whole purpose of shared decision-making is lost. During shared decision-making, you are using research evidence to inform that decision. But if you are using poor quality evidence, then the decision made would also be poor. There is also some uncertainty in communicating about uncertainty in information. So we don't know how best to communicate uncertainty information to patients. So whom should we provide this uncertainty to, and how best to communicate this to them? That's a research question. So what can we do to use evidence-based medicine more effectively? Now, there are several measures that we could think of. In terms of clinical practice, we could develop clinical practice guidelines using appropriate methods. That means that we will have the right information to make the decision. And we should encourage shared decision-making as far as possible, accepting that there are some challenges in shared decision-making. In terms of clinical research, we should design, conduct, and report high-quality studies. And we should conduct more studies on patient values and preferences. We saw that patient values and preferences is an important component of evidence-based medicine, but there are very few studies that look at what others in similar positions decided. That sort of research would be really helpful for patients. You can also do methodological research. For example, you could look at, or you could research about methods to improve shared decision-making. We could also look at the different methods to predict treatment effects and identify which one is better to provide treatment effects for individuals rather than the average treatment effects. So that would tailor the information for an individual, and that means that you could actually make better decisions tailored to the person. This is a list of references that I have used to prepare my lecture, but I have also put in some of my own thoughts in this lecture. Thank you very much for your patient listening.
Thank you for your lecture, Professor. So we do have quite a lot of questions, but we'll start, I think, from the more close-ended ones, and we'll go to the more contentious and more complex ones first. So someone has asked, what is a simple definition of evidence-based medicine?
It's about using the best research evidence, using the best available resources for that particular person, taking their preferences and values into account. So the three components, I would say those, all three go hand in hand.
That's great. And adding on to that, Allison asked, isn't evidence-based medicine already widely practiced?
No. That's a contentious, that's
a
provocative answer.
Thing, yeah.
That's a provocative answer. I can tell you that we wrote a paper on clinical practice guidelines, and the first paper is about how whether the clinical practice guidelines on laparoscopic surgery is evidence-based. We found that only a very, very small percentage of recommendations across all research or clinical practice guidelines published in 3 years, very small percentage actually were based on evidence. So people were actually putting in their opinions and portraying them as evidence. Now we are actually, we've taken a leap forward, and we have looked at the guidelines on liver cirrhosis or advanced liver cirrhosis about some of the major organizations. And surprise, surprise, they were actually very poor quality. So my answer is no, evidence-based medicine is not practiced widely.
And following on to that, someone has asked, and I think it's quite relevant, which is why I'm putting it here first. Do you agree that evidence-based medicine is limited to whether a healthcare provider has access to that clinical research practice? As in, like, what barriers are there for people accessing or following evidence-based medicine?
So there are, in my opinion, there are various barriers, and starting with as they rightly pointed out, accessing the right evidence. These days, that is not so difficult in that the clinical practice guidelines are open access. But then it's the evidence that underpins the clinical practice guidelines that are not open access. So that makes it more difficult for people to access the underlying research that guides the clinical practice guidelines. So, so yes, towards open access, and in fact, we would say openness and transparency about the data itself. So people can look at the data and do secondary analysis. I am fully aware that anonymization of data is a hornet's nest. Now people can, if you want, re-identify a large proportion of anonymous data based on by connecting lots of other data they are collecting about the patient. So it's a huge issue. So my thoughts are you should try and develop algorithms that actually prevent re-identification and use those algorithms rather than saying we can't share data. So that is a major issue. And the other thing is learning materials to practice evidence-based medicine is also behind closed doors. So people are not able to access these. So we need more of open access guidance about performing research systematically and using that systematically in medicine. So yeah, all of those are valid. I mean, the question is a very valid question, and I fully agree. There has to be a lot of things that have to happen. I always say you can't solve everything overnight, but we should progress towards solving these issues.
And related to that, in terms of healthcare professionals and their access to it, someone asked, how much time is really available for healthcare professionals to consider these practices in the workplace and to implement them on top of the workload and, you know, constant education they already have?
I fully agree that it would be impossible for a practicing clinician to be able to research everything on the topic, and this comes back to reliable research being gathered by people and interpreted in a reliable way. So it's about trust. And my clinical practice guidelines paper was, are laparoscopic guidelines trustworthy? Unfortunately, the answer is no. So we need to make sure that there is trustworthy clinical practice guidelines developed, and people are able to follow that. The clinicians are able to follow that, and it is possible to customize the practice guidelines to the individual hospital, even according to the resources available. Yes, that is perfectly possible, but more research needs to be done on that. And in fact, I am trying to do some research related to tailoring the treatment in terms of the individual rather than using average treatment effects. So that is an ongoing research field in this evidence-based medicine field.
And there have been some questions about, well, actually, these are two questions which I'll put into one. So Ines has asked, how much of medicine is evidence-based? And someone asked, like, addition to that, if it's not based on evidence, then what is it really based on? What do clinicians take account instead of, you know, as we mentioned, these systematic reviews, and we have RCTs, what do they really use?
So I can't give a number on the percentage of people who use evidence-based medicine. About 20-30 years ago, in the book by Sackett et al. In the evidence-based medicine book, I forgot the name, sorry. It's related to evidence-based medicine, and in that, Sackett and colleagues say that a dean looked at some medical students and addressed them saying, you will learn a lot of new things, and 50% of them will be wrong, but we don't know which 50% is wrong. So, so evidence-based medicine is, we don't know. There are lots of treatments that don't have any evidence for benefit, and still they are continue to be used. And there are various reasons, and majority is people don't understand evidence-based medicine, but there can be also vested interests in either continuing the treatment or discontinuing the treatment. So, so this is why you need an independent body to actually provide that evidence, which is completely free from any industrial influence. We can't blame just the industry, academic influence as well, because academic promotions depend on how well, if they invented a new intervention and whether if it worked, then their promotion is going to happen. If it did not work, then they may not get promoted. So, so what's the right thing to do? We don't know, but quite possibly an independent, completely transparent body developing all the evidence might be an answer.
And I think that also answers the question of when did evidence-based medicine start becoming an important part of treatment for patients. We should move to some criticisms of evidence-based medicine. There's quite a lot of questions about it, or even specific criticisms that some of the audience have placed. So first one by David. I'm sorry if we missed it earlier, but it says, would you agree that the strength of evidence tends to be overestimated? And as you mentioned previously, like hubris is, as he mentioned as well, hubris is a problem. Statistical misunderstandings, such as mistakenly confusing the p-value with a false positive risk, the pressure to publish, as you mentioned, like academic influence, and the financial conflicts of interest. So do you think that the strength of evidence tends to be overestimated?
I absolutely agree. I'll just give you an anecdotal incident from my own situation. I do lots of systematic reviews, and I sent a systematic review to a top surgical journal. Now, if they said the methodology you have used is poor, I would fully agree. That's a good reason for rejection. The reason for rejection, they said, is because my conclusions included uncertainty in decision making, and they would not publish studies with uncertainty in decision making. So clearly, that is evidence that people are after results, are under pressure to say something positive, even when there is nothing to say positive about a treatment. So, so they want definitive answers. Clearly, that you can only provide definitive answers if the study quality is good. And if you say that the study quality is not good, and this is what the evidence is, and you have to change practice, they don't like it.
Yeah, you mentioned how controversial that can be. So actually, quite similarly along these lines, we have two questions which are quite related to. And one is asking about, can medicine result in healthcare professionals relying more heavily on evidence that can be tested for and neglecting those intangibles that obviously contribute to patient quality and healthcare. And similarly is by implementing like the efficacy of given treatment and implementing this evidence-based medicine process, we neglect certain treatments. For example, someone said homeopathy is believed by many to be effective, and some people, obviously medics, you generally do disagree on that front. So to what extent does evidence-based medicine miss out on certain parts of the knowledge base that is out there, and when does that trump what patients believe in or what doctors currently still do believe in?
So to sorry, Sean. I was too focused on the second question, because I'll answer the second question and then you can repeat.
Yeah, we can go back to the first one. No worries.
Yeah. As far as I am concerned, whether it's homeopathy or some other form of medicine, as long as there is evidence that a treatment works, I don't think when I say when a treatment works, it results in better benefit or more benefit than harms in comparison with the existing treatment, I don't see why you cannot adopt it to clinical practice. So, for example, for malarial drugs, this was taken from Syncona barks, and for heart failure, you use digitalis, and that's from a plant. There are lots of plant products. So I don't see why you cannot use alternate medicines as long as you put them to the same test and rigor as the conventional or Western types of medicine. So I don't see why we should distinguish between them. Medicine is medicine, wherever it originated. So that is the answer to the second question. Can you just
yeah, we can go back to the first. But just to add on a little bit to that as well, we know that, for example, in cancer, chemotherapy-induced fatigue, ginseng, we know that it also can possibly help based on some systematic reviews, even though it is, a traditional Chinese medicine, alternative medicine. But like I agree, if we do enough, there is enough evidence for it, there should be no reason why it shouldn't be implemented. And the first question is probably about, so I'll read it out loud. Can evidence medicine result in healthcare professionals relying more heavily on quantifiable evidence?
I got it. Yeah. So it relates to, so the answer to that is, if you are looking at research evidence in isolation, then you might actually conclude in this way. But we are talking about the evidence-based medicine being used in the context of shared decision making. So this means interacting with the patients, finding out what their preferences are, what their needs are, and tailoring the information based on what their needs are. So it doesn't take away if you want, the finer nuances. In fact, you're just putting those in a framework. If you use the shared decision-making framework, you're collecting that in a systematic way. What preferences do patients have? Do they want to be told about uncertainty? How do they interpret uncertainty? Is their educational background? Based on their educational background, what do they want to know? Based on their cultural background, what do they want to know? All those questions are actually incorporated into the shared decision-making model, where you have to tailor the information according to the patient. So if you are looking at research evidence in isolation, then yes, but you are missing out the two other parts of evidence-based medicine then.
I mean, just to add on really briefly about that, I think, we see a lot of like guidelines as well are more patient-based, with flowcharts and pathways of, if your patient has expectation, we should go for this, and so on and so forth. So we have a couple of questions more on the methodology or the scope of evidence-based medicine to say. So one person asked, how can evidence-based medicine be used to treat patients with rare diseases where there isn't a lot of studies or research, that is out in literature?
I fully agree that you're not going to be able to use randomized controlled trials, or it's very difficult to use randomized controlled trials to guide treatment. So in this case, you might have to settle down and use the best available research evidence, but you have to interpret that evidence correctly. And if there is uncertainty, you have to use that uncertainty. The only other way that I can think of is people bringing, internationally coming together and conducting large trials for these rare diseases. But even then, it depends upon what you call as rare diseases. If you're talking about less than 1% of population having, then it's not so rare, so difficult to conduct a randomized controlled trial. But if you are talking about 1 or 2 people developing a rare disease in the world every year, then I don't think you would be able to conduct a randomized controlled trial. it's very difficult. So you have to use what's possible. And in this context, there is a N of 1 studies, for example, trying out different treatments in the same individual, of course, on the basis that they don't get cured by one of the treatments, or the disease has progressed so much between the treatments that you can't really assess whether the progression was because of the treatment or because of the natural history of the disease. So it's difficult. We have to, so we are not saying that it solves every single problem. We want to solve as many problems as we can.
And these are two questions that are quite similar on the same field, so we'll try to combine them into one. So one says, how would evidence-based medicine be applied in an area where medicine doesn't really have good evidence? And how do you determine what studies are good evidence, are good quality?
I lost the first bit.
Oh, no worries. So it says, so how would you apply evidence-based medicine in an area that doesn't really have good evidence?
Okay.
And how do you determine that?
Yeah. So in terms of quality of the studies, you have to use what's available. And when there is uncertainty, you have to explain. I mean, in my opinion, you have to express that uncertainty to the patient and go by what their preferences are. So that is one, but you have to do proper quality research, and that means adequate funding, adequate funding to do a proper research, and adequate number of patients, and so on. Yeah, that's the answer. There may be some uncertainties that we are never able to resolve over a lifetime, but that's the fact of life. You accept that you're going to solve 95% or 98% of the problems, but there would be
not all of them.
Yeah.
I mean, also just quickly, this is why we also have these conversations, and that's why we get audiences here for them. Hopefully we inspire some of you guys to come to UCL and do this research with us to answer some of these questions that everyone has been asking and we don't have the answers to. And hopefully the next 10, 20 years, we get some of them back. So we have some questions about patients specifically, and about the conflict between patients and evidence-based medicine. So one of them is, Leah says, do you think patients are becoming more and more invested in making shared decisions? And have you noticed any specific trends?
There is an active promotion of shared decision making in NHS. That is one that is in the NHS plans. Hopefully that's what is happening. And certainly, I mean, I must admit that coming from a different country where shared decision making is very much less, here in UK, there is reasonable shared decision making, or perhaps it was me who was doing the shared decision making all the time. But generally, patients are involved in their decisions here, I think, in UK. I'm not so sure about lots of other countries.
So, and Simon asked, but what if, in the same topic as well, what if there's a conflict between the patient belief or their preferences and the clinician's belief, assuming it's based on evidence-based medicine? Who gets to decide in the end in this conflict?
Who's the treatment for?
Simon, I think you have your answer. I think the patient just gets to decide, but obviously the nuances will have to be explained, and consent and so on and so forth, but assuming those, patient gets the final decision.
Yes, one of the aspects of shared decision making is about making sure that you understand the patient preferences, and you put yourselves in their shoes and see what they would decide. And if that decision is different from what the patient actually makes, then there are possibilities. There are a couple of possibilities. The main possibility is that patient did not understand the evidence. The other possibility, of course, is that you didn't understand patient preferences fully. So these, in my opinion, are the two possibilities. That means that you start again. With getting patients' preferences, understanding whether that's finding out whether they understood the evidence, and if they if you feel that they have understood the evidence, then you have to respect patients' decisions.
Mhm. And then with this is also quite a similar question regarding tailoring information and what you mean by that. This person asked, when you talk about tailored information, do you mean finding ways to describe things or educate patients in a way they would understand, or do you mean by something else?
I'll give you an example from my own clinical practice. I usually describe everything to patients in a detailed way. Openness, transparency. But there were, I had one complaint, and the specific complaint was that they didn't ask for the information, but I was giving them all the information, and that upset them. So tailoring the information means, do you really want to know all the information, or would you like me to just give you what is right and what is wrong? So it is about that. I've just had one patient. All the remaining people, they are very happy that I'm trying to explain things and involve them in the decision. But there was one patient who was upset. It was not even okay, I don't care sort of attitude. They were actually upset by me trying to give them the information for them to make the decision.
Mm-hmm. So just a quick time check. We have 5 minutes left, so we're probably going to go through roughly about 2 to 3 more questions. There's plenty of them coming in. So I'm going to pick, there's one question currently about the idea of success, and I think we can relate to more than methodological success. So who decides what is successful? So, and this Jay, give an example. So the surgeon will say, the surgery was very successful. The tumor is out, or the replacement was good. But then the patient, in terms of the patient perspective, might not have been successful in terms of adapting to it, or physiotherapy and so on and so forth. So who and where did they draw that line in terms of effectiveness?
So effectiveness should be decided by patients, because it's for them. So we have the COMET initiative. It's core outcome measures in effectiveness trials, which look at the important outcomes that should be reported in clinical trials, and in that, that's jointly developed with patients and clinicians and researchers, public bodies, and so on. So, so those core outcome measures should be the first port of call for anyone who is trying to do clinical research. Of course, within that core outcome measures, you might want to choose some of the things that patients identified as most important to them. And that should be how a treatment should be measured as successful or failure.
Mm-hmm. So more patient outcome based, which is currently the norm. So we have some questions, I think, coming in as well. Let me give it a quick look. And this, I think this is quite an interesting one to start wrapping it up on. And it goes, what effect has the internet and Google had on shared decision-making, as patients can now do their own research and as from evidence-based medicine and on their own treatments in terms of their patient decision and the shared process?
So this, we are talking about uncontrolled websites which give all sorts of information, and sometimes you can be receiving biased information as well. And this is why, and to a large extent, I would say, even if you go to the major association websites, it's biased. And that's why I said you can't trust clinical practice guidelines on laparoscopy. And next I'm going to say you can't trust clinical practice guidelines on liver, advanced liver cirrhosis. So whom do we trust? We don't know. So so this is why the whole way that we think about evidence-based medicine and who develops clinical practice guidelines has to change. So, or at least somebody reviewing the information on all clinical practice guidelines and then saying, okay, they are saying the truth. No, this is all lies. So, so we are in a world where we are guided by wrong information, I would say. But that's not the fault of evidence-based medicine. we should aim to reach a stage where correct information is available and right decisions are made based on those correct information.
Mm-hmm. So with roughly 3 minutes left, let's see if maybe one very quick question I can answer if we end it. So I think there's quite an interesting one about conducting the methodology itself, proposed by, I believe it's Liam. Why are there not trials comparing the known evidence-based medicine for a particular clinical entity versus the clinician lead care in an average clinical environment like the NHS? So in terms of the NHS, why are we not comparing within that, how we're using it?
So most people would be reluctant to say that they are not using evidence-based medicine. Whether they use evidence-based medicine or not is a completely different issue. But it would be very difficult to randomize people between following evidence-based medicine and not following evidence-based medicine. And this, because if anything goes wrong, when you do something that's not in clinical practice guidelines, then you are in big trouble, essentially. So people would be reluctant to say that, even if they do that. And to me, a better way of judging whether people are following evidence-based medicine is just looking at clinical practice guidelines and whether you can trust them. So, so in UK, for example, you are expected to follow clinical practice guidelines. So, so it would be very difficult to do a study where you say, okay, we randomize people to following evidence-based medicine and not following it.
Thank you. So very sadly, we're really out of time. I know there's still so many more questions. They're so interesting. We could go a lot more into depth in there. However, before we end, could you guys please provide us with your feedback about today's session by filling out the survey, which will be sent to you after this event. We'll be resuming our public lecture series in September. So in the meantime, we hope that everyone has a fantastic summer. Enjoy the sun. Thank you for all of your comments and your questions. And thank you, Professor, for an excellent lecture. And to everyone, please have a great evening.
Thank you very much for attending and facilitating this. Thank you.
Thank you, guys. Thank you for coming.